on business and society. We'll be covering a total of 6 areas, ranging from the future of work to smart cities and communities, changing consumer, circular economy, and many more. So today, however, we're looking at the first of these areas. We're focusing on the health sector. Okay, so we're delighted to be joined by Dr. Johnny Walker, an Australian-trained interventional radiologist and international serial digital health entrepreneur who founded the enterprise Jinga Life, which provides a digital health interface through which users can record health information on things like medications, blood tests, and allergies, as well as access digital images and records, store documentation, and connect wearables. So I think you'll agree that it's very relevant for today's world. So feel free to send in your questions during the session using the Q&A function. Okay, so you'll find that at the bottom of your screen. Please be aware that the actual chat function is disabled, so that's a different thing. So only use the Q&A tab. We will then compile the questions, and I will ask Johnny to address as many of them as we can get through in the time available. So I'm looking forward to your questions, and I suppose without further delay, I'll hand you over to Johnny. Johnny, you're muted there. Molly, you can unmute Johnny there, please.
Molly, can you hear? Hi, guys. Gary, if you can hear me, could you give the thumbs up? Beauty. Guys, I'll bat on. Molly, if you could take me back to the first slide, please. And I'll take over now, Molly, if that's all right. Okay, guys, sorry about the first hiccup. We knew that we wouldn't get through this without a few problems. This is the first time I've ever presented Prezi virtually. Normally we're flying through on a live stage. But look, guys, thanks so much for the invitation. I really do appreciate it. And Theo and the crew have asked me to talk about the future of healthcare from a digital perspective, and I truly believe it's going to be a consumer-led digital tsunami. But the real question we're all asking ourselves tonight is, can innovation survive and thrive in this COVID world that we find ourselves in? So what I want to do is give you a little bit of background of where we came from, which was far from COVID, in outback Western Australia, how we grew into an international enterprise, and how over the last 10 years we've really been evangelising, empowering the consumer of care and the real captain of care, who we call the Jinga, in a way that they've never been empowered before to help care for the people of the planet. So once again, thanks for having me. I'm going to talk pretty quickly, and let's hope it goes. So my name's Johnny Walker. I'm a clinically active interventional radiologist and nuclear physician. I'm based at the Hermitage Medical Clinic, trained out of Australia. And for those that are already questioning it, I'm an Aussie and I'm not a Kiwi. But I work with a fantastic team at the Hermitage out there off the M50. My background, my dad was a country GP, became a country surgeon in a beautiful little wine growing area called the Hunter Valley in New South Wales. And he had no technology whatsoever, other than his stethoscope and the old doctor's bag. And then we had a donkey line to try and find out where Dad was. And we used to have to connect to all of the different farms within the valley and eventually to the hospital to be able to reach him. And God love him, I think he'd be astounded with the technology we have available to us today to help us look for people. I've been blessed on a pretty magical journey throughout my career. After school, I went off to Cape Town there at the top and lived at the foot of Table Mountain in Cape Town at the Rhondda Bosch Boys High School, where I did my Rotary year, back into Sydney there as we go around the clockwise, where I did my university and early training at the wonderful St Vincent's Hospital in Darlinghurst in Sydney, crossed to Perth for a pretty magical time on the beach in Cottesloe, and then had a mentor that kicked us out of the country to centres of excellence around the world. I was fortunate enough to win the Shering Fellowship to the Royal Postgraduate Medical School at the Hammersmith Hospital in London, where I saw the first ever truly digital and filmless diagnostic department of its type in the world. sold to the NHS as being cost neutral for a total cost of 28 million euros, which no one obviously could afford. But I thought, boy, if this is like the colour television and it becomes cheaper and faster, more effective, more efficient, we'll be able to have this sort of technology in little parts of the world where I grew up in the Hunter Valley. I was rescued up to Cambridge, there in the bottom left-hand corner, magnificent year of my life, and then across up to Stanford, where the Americans, as opposed to the English, and I hope I'm not offending anyone in the audience, they tend to pour petrol on you rather than water you down. And it was a truly wonderful year of my life, where they offered you the opportunity to come back to America and take up an associate professorship. But in so doing, I had to get out of the States, go back to Australia, get my visa sorted out, and I ended up getting stuck there with a bureaucratic bungle, and I ended up going and doing a locum high up in the bush. And these were my first 5 patients. And my role was to do ultrasounds on each of these ladies. And I always say, what do they have in common? My little daughter, Charlie, always said, Dad, you know, that's the easy bit. They all went to the same hairdresser. And look, they're a magnificent breed. They're Aboriginals. In fact, here we have 3 generations. We've got the grandmother and 3 of her daughters and then another granddaughter. Unfortunately, the wrong number of fathers for how all this happened. But my role was to do ultrasounds on pregnant Aboriginal mums. With Aboriginal mums, they're genetically predisposed to diabetes, and diabetic mums hang on to the sugar. The sugar goes across the placenta and it gets sucked up by the young little fetus, the developing fetus. And the fetus becomes quite large. And then when mum goes to deliver the little baby, the baby gets stuck, and we end up losing both mum and the baby during that stage of delivery. It's something we call macrosomia, macro meaning large, somi meaning body, so large-bodied babies, and totally diagnostic, able to be diagnosed, ahead of delivery, and yet out there was just no service whatsoever. And I'd come from these centres of excellence where we had absolutely everything at our fingertips, and then suddenly I found myself in this magical land where the red soil and the blue skies, where these people basically had nothing. And so on that particular day, it was 48 degrees. I did 48 mums out of the back of an old truck using an old mobile ultrasound and a diesel generator with Albie, the driver, who was responsible, as I've always said, for a lot of these pregnancies anyway. And I saw this on the 11th of the 11th, 1995. So almost 25 years ago next week, I saw this image where on the left, you've got the perfect picture of a little 18-week gestation. And on the right, you've got a terrible dilemma of obstetric crisis where all of the ingredients of a little baby become horribly intertwined, and they form this highly vascular tumour, which has got the ability to spread around the body and metastasize and ultimately cause mum's demise. And that's called a hydidiform molar pregnancy. In those days, had to be carefully dealt with a full hysterectomy. You couldn't spill any of this into the abdominal or pelvic cavity, or else it would seed and start spread around the body, and mum would perish ultimately from bleeding into those secondary organs. And so it was a massive dilemma, and I just felt incredibly isolated, well removed from these centres of excellence where I'd been blessed to train. And in those days, the only solution we had was, if in doubt, fly it out with the Royal Flying Doctor Service. And the Royal Flying Doctor Service is a fantastic service. It operates over a massive waiting room throughout Australia. But in Western Australia, over there on the left, on the western side of the country, we've got just over 650,000 people living outside of Perth, some 2.5 million square kilometres, with Australia being around about 7.6 million square kilometres in total. So WA is 4 times the size of Texas. It's a pretty big paddock, and usually when you throw that up, it puts the Americans in their box. But it's made up of very small, isolated communities, even to this day, spread over this huge geographical area. So the only way of connecting them from a practical point of view was to try and link them over the 3K copper wire, the old telephone system that we had, and try and build a telemedicine network so that they could be linked through to centres of excellence so that we could look after them. But it was that particular night that I felt this glaring injustice where I'd been blessed to work in these centres of excellence, and yet out here in the dirt, patients were getting next to nothing. And so I felt this compelling need to redesign. And guys, I want you to think about this compelling need to redesign, because although this happened just on 25 years ago next week, we find ourselves amidst this massive challenge on a global scale that we've never seen before. And there's a compelling need to redesign. design ever in time to make it easier and safer, more effective, more efficient to care for people in a different way than we have to now. So at that time, I didn't have any ads up into all of this Australian, and I wanted to build a system that we had at the Hammersmith. I didn't have the in fact, I had no money. I was £35,000 in debt, but I had a very simple telemedicine network so that I could provide an outpatient clinic to these patients in the bush. I started with a little mobile ultrasound unit, which you see there on the bed and in the box as we put it into the truck that day. And I just thought, look, we'll start with this little mobile ultrasound unit. It was the first one available in Australia, and Toshiba wanted to sell it into the market. They wanted 60,000. And I said 20,000. We settled on 30,000. I didn't have any money. They said, could I pay in 30? I asked for 90 days. We settled on 60 days, and away we went. And that's how we actually ended up building this little practice, looking after small communities fragmented all around Western Australia, driving from Harvey, Collie, Donnybrook, Bridgetown, Manjimup, Margaret River, and offering this service at point of care in a way that had never been done before. So we actually, bit by bit, we built our little footprint out across the Western Australian landscape. Again, all on a copper 3K phone line. Now 3K, guys, I'm here trying to get 2 meg into my house, and yet 3K we were able to link these little communities. Gary, is this working, mate? Are you able to hear me and everything? Okay. So bit by bit, from a 3K network, we went to I remember we went to 56K, went to 128K, 356, I think it was, 384. And then I thought, oh my God, the heavens have opened up. And then suddenly this thing called the internet came along. And that was the release of the handbrake. That was the biggest inhibitor for me, was to be able to connect to centres of excellence around the world. And I was able to open up my network where I trained in Cambridge and Stanford and various other centres of excellence around the world, and ask them if they could give me second opinions for all of the disease that we were beginning to find in the outback of Australia. And so bit by bit, we built this global network, which grew under the banner of Global Diagnostics, and it still operates under that banner today. I remember we did 4 patients on our first day, 3 the next day, 2 the next day, and I thought, oh my God, what have I done? But now Global Diagnostics and its affiliated entities are now doing some 3,500 patients around the clock, around the world, every day, and an enterprise I'm really, really proud of. I exited that through a management buyout, and I backed our management team to go on and build something really extraordinary, which they're well on the path to doing. And the night I exited, I think around the world, we had 469 staff, all completely and utterly devoted to building something special and changing the way we care for the people on the planet. But that left me with a real dilemma as the founder, because founders, they love being in the thick of it. They love, the real joy of and the excitement of building something from nothing. And certainly that's what drove me, and particularly in my own field, to think that I could have that sort of ambidextrous life of the clinical side, which I absolutely love and passionate about, but also the entrepreneurial side, to be able to actually go out and try and make a difference in what has traditionally been a very, very hierarchical, very patriarchal industry in healthcare. So what next for JW? Well, listen, I actually never stopped doing the fun stuff. I always maintain my clinical commitment. I still, to this day, as soon as this is over, I've got one more talk to give later on with Huawei, and then I'm off, and I'll be reporting and working. I operated all day yesterday, and it's I love what I do, and I won't give it up, because that's where I see the pain points. That's where I see the real smash areas and real opportunities for us to bring about change in a sensible and safe way. Look, I'm not going to tiptoe around this. I'm blessed. I work in a pretty special, beautiful old shed called the Hermitage, which is the mirror image of the Galway Clinic. And it's spectacularly beautiful from an architectural design point of view, from a patient flow point of view, and from a wellness point of view. It's a gorgeous place to go, even though we have an enormous focus on cancer patients, but across the board, our patients, I think, adore being there. And certainly Mary, who I had to do a liver biopsy there on last week when she was sitting out here in the foyer. She said, just for a moment, Johnny, I forgot why I was here. And I think that's a real testament to the architects and the designers who brought this magnificent building to life and allowed us to care for the patients the way we do. But I felt that maybe, just maybe, there's time for one more disruption, because although I'm blessed and I'm working in this magnificent hospital, I still think the healthcare ecosystem is completely and utterly flawed. It's grown up and evolved in a very ad hoc way, a very chaotic way. And in fact, there have been, there's a real incentive to stop people coming in and trying to disrupt and change the way we care for people, because there's so much inbuilt obsolescence within the chaos of the ecosystem. And so I thought, how can we go about changing that? And you might say, well, look, Johnny, what's the problem? We've got a hospital-based system. It's a system that works. I would say that, look, it's still fundamentally a doctor-centric focus. And you might say, well, what's wrong with that? And as a doctor, I'd have a hard time defending it. But as a doctor, I truly believe that it's unsustainable. It is unscalable. We know it's unsafe at times, even though we really, really try and be as safe and as effective as we can for every patient we touch. But we know it's inefficient in people, time and dollars, and incredibly costly. So, is it the best model of delivering care? And I don't think it is. And so the solution, it's one thing having a whinge, but you've got to come up with a solution. And I think the solution really is a genuine shift to promoting health and wellness within the community. Now, when you see these slides, guys, I know everyone's out there thinking, oh, yeah, jumping on the COVID bandwagon. These slides have been out there in the domain, for the last 5 years, 10 years, some of them. And I've tried to be able to bring this digital vision to reality. And little did we know that it was going to take a virus and a pandemic to actually put us under the spotlight. But I think now more than ever, there is this compelling need to change the way we care for people and shift the focus from the hospital to the community, within the community to the home. And this is how we can do it. It's just by taking the current models and engineering them in a way that is more effective, more efficient, and using digital technology where and when it's appropriate to actually help us deliver that. Now, to some degree, it's still focused around the GP, okay? I think we're going to see that change, whether that's in-house visits or virtual visits now with COVID. I think we're going to see the nurse really step up. The community nurse, I think, is going to be the saviour of all of this. The dentists, God love them. If you're thinking about doing dentistry, good luck to you. I couldn't have done it, but God love them. We do need them. And this all-important pharmacy team, not only in the high street, but now with the virtual pharmacies, the ability for the pharmacists now to become an integral part of this digital ecosystem that we're trying to engineer, and the all-important physios. And you'd think the physiotherapists couldn't be a part of this new movement. They absolutely can. And they've been probably the most innovative of the ecosystem in moving to a virtual environment to still engage with their patients. But talking of the patient, where is the patient in this new model? Well, in pre-COVID, they're driving to the clinic. They're trying to find a car park and they're taking a number and they're effectively waiting in line like they would at the delicatessen for their sausages. So is this the most effective healthcare delivery model? I would say, look, I don't think it is. And what we really need to do is we need to engage, embrace, enable, empower, and we need to listen and be educated by our people, by our patients, by the users of the system as to how we can make it better. And I deeply believe we can do this now with the technologies available to us in their own home. How? Just by simple enabling technologies. Each of you have one either in front of you as we speak or in your back pocket, and as just mobile, digital, connected, but very, very personalised innovations in a way that we've never been able to deliver before. We can now do it, and there's nothing stopping us. And that is a massive paradigm shift. Now, with COVID, this is becoming less and less of a paradigm shift. It was more of a necessity, a survival mode that we got thrown into in February and March of this year. But up until then, this was just a step too far, and people thought, oh, Jesus, Johnny, he's on drugs. And if he's not on drugs, he should be on drugs, because this is just heresy that he's talking. But I really believe that we need to have a total realignment away from the hospital to the home. And that requires a redesign of the entire healthcare ecosystem, not a complete smash and build from scratch, but over the course of the next 2 to 5 years, now we have this very, very real driver to redesign. And we need to do that and embrace it. And just as we go, I think I need to share with you a really important and compelling observation that I had when I come out of my operating theatre, when I've operated on the elderly 73-year-old man, and I walk out to talk to his carer or member of the family. Who steps up to talk to me? But in my experience, the custodian of the well-being of the family, the gender of that carer in 92% of my audited cases in 16 and 17 is the female. She's the gatekeeper, the shepherd, the protector, often the female, often the mother, more and more now, the millennial daughter, and more now, the millennial son. And now with COVID and now with digital, we're seeing more and more of a democratisation of healthcare. We're seeing more of a sharing, an equal sharing of the burden across the genders of how we can actually go on and care for the elderly in our family. But we call her the Jinga after the African warrior queen, Queen Jinga, the great fighter and protector of her people. So do we truly operate a patient-centric service pre-COVID and even now within COVID? Look, we don't. Where's our patient? They're trying to drive to the clinic with their masks on now. They're parking the car. There's system overload. We lack that personalised information. Often the Jinga's voice isn't heard, and yet she's the most instrumental and pivotal role and resource within the ecosystem. And yet we talk through her over, we talk in Latin, and she feels like she's on this conveyor belt of care at all times. So is it patient-centric? No, it's not. So my deep belief is that we now need to stop and redesign. But how do we do it? Look, the technologies are there, and they're not overly complex anymore. They're off the shelf, they're available, they're connectable, they have interoperability, and that's a mixture of sensors, just smart IT, workflow, which is designed with lean theory and now with COVID on board, and using simple informatics with a very personalised focus, all brought together in a really, really simple way, just like we did with global diagnostics to build something that's very real in terms of a new model of healthcare. And I think all of this should be designed and populated by the gatekeeper of care within the family, and we call that person the Jinga. And I think the Jinga needs to be involved in the design of this new world. And if you had to draw it, and I'm a big drawer, I would put the Jinga and everybody she loves in her family, all the way from the elderly parents through to the little kids and the dog. We don't do cats, but everybody in her circle of care from the 9 o'clock mark over there, where all the way from conception through all of life's milestones, through the sandwich generation to caring for the elderly parents and to that really, really important end of life. We need to be able to use technologies to facilitate the smooth transition through each one of these milestones while staying connected to the GP, the all-important community nurse, the physio, the dentist, the pharmacist, and the specialist, all through the palm of your hand, through smart technologies, so that we can map the well-being of each and every one of the members of our family. There's my little man, and we've got all of his immunisation and allergies, and now with COVID, the whole vaccination thing is coming alive at last. And so we built an app, a companion app, which is fully GDPR compliant and linked through to a medical grade platform, which allows all of the appointments and scheduling, medications, allergies, everything you'd expect to have in a medical app, as well as reports on blood tests, the imaging transfers, so you can have your own private film bag. And we built that to the point where we launched this with Affidea in the market in the August of last year, and very, very rapidly went to over 175,000 patients have opted to use that and download their images into their own private film bag. So you might say, Johnny, look, is this really the future? Well, I think that, we now know that there's going to be 75 billion connected devices tracking health by 2025. The Internet of Things is upon us, and pretty well anyone who has access to a device anywhere, in any context, in any domain, can now come in and be a disruptor in pretty well any domain. And what we wanted to do was bring Jinga Life with the empowerment of the mobile app, link it through to a digital first aid kit and videos and education to create a solution that might be able to fuel a tsunami of consumer-led disruption. And I think it is going to be the consumers that lead this disruption. It is not going to be, sadly, the politicians. And I think we really need to be able to pour petrol on them in a way that they've never had before. So where would you start? I think you've got to follow the life cycles from womb to tomb with pregnancy and early life, we can now track basal body temperature, so we can track ovulation to either get the wedding tackle out or put the wedding tackle away. And then, with as the little one is growing, we can have all of the digital electronic health records available. Teleconsultation, which was only dribbling along there towards the end of last year, is now absolutely accelerated into a new world of virtual consultation, where people of all ages now are becoming very comfortable with doing so. And all the way from the young ones now, with the various monitoring sensors we have, the childhood trackers, the immunisations, which is, as I said, is going to become so important now with COVID, all the dental records and various other biometrics. And then as they get into the teenage years, they're going to want their own privacy and all of the data protection that goes with that. It has to be mobile. They're going to want to be travelling, and also that mental health side of things, along with their diet and their nutrition, their hydration, and empowering the teenagers in a way that they've never been before. And at the other end of the spectrum, the chronic diseases that are just taking up so much of our people, time and dollars. It's where 80% of our healthcare costs are going to go by 2025, and 40% of adults are going to have some form of chronic disease within the next 5 years. That's upon us. Diabetes, it's rampant. Half the world's diabetics don't even know they're diabetic, and we've got close to 350 million globally. And there's a massive number of technologies coming into the space, whether it's around the little tattoo, the smart corneas, the GlucoTrack watches, etc. There's a whole industry burgeoning around monitoring of blood sugar levels and the monitoring of and maintenance of diabetic stability. The COPD patients, the smokers, costing us a massive amount of money. How can we monitor them at home? And then the cardiovascular disease, which is still there, as evil and as silent as it is. And what technologies such as the AliveCore, the Vital Connect, the Apple Watch, the Garmin, the Fitbit, everything's coming at us, but how do we put it together in a way where we can actually add real sense and sensibility to what we're trying to do? Don't think that the elderly aren't connected. They're connecting more and more every day on more and more devices for more and more offerings and solutions. They're already using it to build their communities, organise their transport. They're organising all of their appointments. They're taking their medications, and they're wanting to move away from the paper electronic health record. We've actually gone and created a digital first aid kit to actually bring these sensors into one jewellery box, if you like, and then link that directly through with virtual consultation, so that ultimately when a patient goes to see their general practitioner, they could be prescribed the digital first aid kit with the appropriate sensors which are personalised to their brittle diabetes or their COPD or their post-cardiac event. And if there's any variation from baseline, it sends an alert through to the GINGA, but also the diabetic care team, the juvenile asthmatic team, etc., so that we can bring about an intervention in a virtual digital way rather than having to bring the patient in or waiting for them, which is even worse, to present late into the hospital in the acute care setting. There are methods of monitoring with Dignity around smart beds, smart nappies. These wonderful guys out of Liam Casey's PCH they built the smart nappy, which they then sold for 12 million, would you believe, at prototype level, keeping patients dry in nursing homes so you don't have to wake them up, and in knowing whether or not the concentration of their urine indicates that they've been taking enough water to stay hydrated. We've got apps now that allow us to stay active, not only from a physical point of view, but from a mental point of view, and the beautiful mindfulness apps out there, such as Headspace and various others. And then we hit this stage of life, which is the end of life, and that how can we bring technology around to have death in a dignified way, and have everybody in the family linked from a communication point of view, but also afterlife, not only managing the gathering and the scattering, but also the disbursement of assets and wills. Medication compliance is just horrific in the United States. We know that 14% of chemotherapy patients aren't taking their drug by the 7th week of the cycle. When if they're not taking the drug, how can it possibly be adherent? Everybody now wants everything on demand, whether it's Airbnb or Netflix or Uber or Tinder or whatever else. We understand it all started with porn, actually, the whole on demand. But now more than ever, they're having the expectation that they can have their health on demand. They want their medications delivered to the door. With now Amazon making acquisitions in this space, Amazon are now going to become, the biggest deliverer of home dispensed product on the planet. We've seen various solutions now emerging where we can have dual-facing dispensing of medications, so no more having to go and visit the pharmacist to get your drugs. This is the most beautiful little piece of kit that I've ever seen down at Computer Electronics Show, twice now in Vegas. Right now we're going through a little change of ownership, we'll call it, but the most magnificent little companion tool that I've ever seen in a home, run by voice recognition, dispenses the medications, but it's a magnificent little companion app and solution for the elderly who want to live longer with dignity within their home. So the benefits, if we get this right, guys, are huge. What's the byproduct that everyone's so scared of? Well, it's all about data, and the problem is this data never ever sleeps. And it's everywhere. We've got predictive software, not only for the smart ager, but if we could get that through to the primary care team, the acute care team, that could go through to the public health planners and also the payers and the regulators, then we'd really be able to get some intelligence out of this data. Now, the problem is the data is absolutely drowning us. There's a tsunami of data that every one of us is wading through every day. But in healthcare, there's just buckets of it. And, you know, when I look at all my PET scans and MRI scans and CT scans, and any other type of scan, parking the human genome and everything else that comes with in terms of the data load, there's a massive amount of data that we're drowning in healthcare alone. And the real challenge for us is to try and extract some meaningfulness out of that data. Otherwise, we're just going on to Dr. Google and trying to come up with, a solution in a half-baked way. What we really, really want is that magic bullet. We want actionable data, which is backed on meaningful assumptions and analysis. And we're seeing so much of that at the moment. So look, very, very quickly, a sneaky peek into the future. Now, this was all pre-COVID, okay? So none of this was COVID. And I'll get to COVID in a sec. But, VR and AR, it's upon us. Now, look, it's not for everybody, but my patients at this stage, they love it. It allows us to connect with them in a way that we've never been able to do from their lounge room and from the clinic. The electronic stethoscope now, it's almost certainly going to be superseded by the butterfly ultrasound, which is as small and will now be carried by young medical students and doctors in their pocket. The digital thermometer, everyone said, oh no, that will never work. And now, of course, we're so familiar with walking into stores and restaurants and etc. for having our digital thermometer done in a touchless way. Young Catherine, again from PCH down in California, in San Francisco with Liam Casey and the team, this ambulatory digital blood pressure monitoring using radar for continuous monitoring of the blood pressure. The Compression Kinetics boys, these guys are phenomenal. Sold to Nike, the very smart sock, which basically sets up this compression of the calf and stops deep venous thrombosis, also removes the metabolites from elite athletes. Gesturing, this wonderful, wonderful team who came over to us from Croatia. So when I'm in operating theatre now and I'm fully scrubbed, I can now just gesture to bring up the images or take the next image or zoom it up or do my measurements rather than having to get my team members back in the control room to do that. The robots, guys, they're upon us, and we need to embrace them in a way that we've never done before. They never go to sleep. They very rarely feck up, but and they never drop the scalpel, as I say. This is a robot which actually basically accompanies you from the entrance of the hospital or the clinic throughout the wards and down to the CAT scan room and what have you. The CyberKnife, which we've got installed out at the Hermitage now into its 6th year for inoperable brain tumour, where a patient now goes and lies on the table, fully clothed. The camera just goes all the way around, and the knife actually cuts out previously inoperable tumour, which is deeply, deeply related to vital structures. 6 minutes later, the patient pops upstairs for a muffin and a cup of tea, and then an hour later, they're in the car heading home. So it's really changed the game for us. The drones, they're here. And we're seeing what Bobby Healy's doing with food delivery now, but the drones are going to be here in terms of delivering medications and all the other frontiers that it's able to challenge. The 3D printing, no longer do we have to go in and guess once we're in the brain to see how big the aneurysm is or how invasive the tumour is. We can actually do all of that on the CT and the MRI and then 3D print the tumour so that we can actually practice going in and playing and extracting it. This millennial conundrum where the millennials are coming out, and I imagine there are some of you on listening to me now, but we need to basically have reverse mentoring where old guys like me, we need to be able to listen and be nurtured and nourished by the wonderful minds that you guys now possess in a way that, again, we've never done before. We need to turn it on its head and really pour petrol on you. The machine learning, look, it's going to be a big part of it. It's upon us. I use artificial intelligence every day to help me in diagnosing virtual colonoscopy, etc. And the AI and the cognitive learning with the likes of Dr. Watson from IBM and the various other Zebras and AI players out there now who are really stepping up and coming to the fore. And I can tell you now, at 9 o'clock at night, I am completely and utterly shagged. I haven't eaten, I haven't slept, and I should not be reading PET scans, which are absolutely pivotal on a patient's treatment. I would much prefer having the AI and Dr. Watson do the first read overnight, and I can come in fresh the next morning, and then collectively we can come up with the most accurate and meaningful diagnosis. The chatbots, they're upon us. We simply don't have enough humans to actually keep us going. So get used to them, embrace them. They'll become better. They'll begin to learn empathy, and they'll become more personalised and human, but begin to learn with them. Blockchain, everyone's so frightened of blockchain. But you know what? It may well be the answer to our problems in terms of a universal, and I mean a truly universal, global electronic health record, which is owned and curated and collated by the patient themselves, linked to all the players. But listen, you think, oh yeah, Johnny, this is all digital stuff. But look, you don't need digital. And this is our little project down in Haiti with the EY Entrepreneur of the Year alumni, where we have a little orphanage down on Île Vache, the island off the southwest coast of Haiti, where we have the Madame Bouvard orphanage. And we go out and we were just agile, mobile, in the boat. Social media was a loudspeaker. And then we do little pop-up clinics using a little shack like that. And then within 10 minutes, we started out the waiting room. And within minutes after that, reception desk. Now, I know there's no 2 metre separation there and there are no masks, but this was all pre-COVID. And there are real challenges down there now that we're going to have to confront with COVID in trying to protect these people with social distancing, etc. But the patients just kept coming. We just sailed around the island saying, the doctors are here, and they came and they flocked. When I look at this, I had to stick, all I had left was the back of a fork. So I stuck it into the end, the lateral aspect of this patient's ankle to get the pus out of it. And then when I went to clean the fork in the water, I looked around and there was the dog licking the pus out of the wound. So who needs a CAT scan when you've got a dog? Man's best friend. 79 adults, patients in one day, 99 school kids we did for a screening program. Just a truly magic day with all the crew that we took out of Ireland. Down there under the program. But look, if we get this right, we can build truly personalised preventative medicine in a way that we've never been able to do before. And we can make it simple so that we can stop patients coming to hospital and look after them within their home in a way that they've never been cared for before. But the real question I ask is, can we do it? Because it really is so hard, okay? And the problem is it just gets harder and harder still. And here we are. What about the challenges? And there's the challenges long before COVID ever hit us. Our own, as entrepreneurs, our own lifestyle, our professional and financial goals. What are our own personal 0 to 2, 2 to 5, and greater than 5 year goals across lifestyle, professional and financial? Because, most of startups are for profit. How do we build it? And from an external point of view, you're going into a legacy system which is embedded with a patriarchal design. There's so much resistance to change. The immune system of the current ecosystem just attacks innovation. And I know I love all of the crew in the HSC and the innovation they're bringing about. Same with the NHS, Health Department of Western Australia and WA. Look, they are trying. They're absolutely trying, and they get it. But there's still an immune system that attacks early startup innovation, and we've got to change that. They're risk adverse in terms of procurement. You've got to have 2 years of audited accounts to be able to tender for something which could be absolutely a game changer overnight, particularly when a COVID hit us in March. There's an anti-startup bias. They don't mean it, but it's cognitive. And they're looking at cost cutting rather than value generating. And they see a lot of what we do now as commoditization, where they want more for less, but ultimately the buyers want the lot for nothing. And that's not a sustainable, investable model. And of course, there's the politics. And I never mention it because I'm politically neutral wherever I am. But you can never, ever let the politics beat you. You've got to keep that fire in your belly. And when the hard days come and the deep, dark nights, you've got to step up and step forward. And you've just got to outlast them. And then along came COVID, this global pandemic, a perfect storm for digital health, or Is it? You know, there's never been a more compelling need to redesign some 25 years after I did those scans in the outback in Fitzroy Crossing in Western Australia. Never since then have I seen a more compelling need to redesign in a way that we've never done before. So we truly need, with humility, without bias, we need to look, listen, design, disrupt, transform. You know, the Stanford Protocol, the NUIG Bioacademy Protocol, a new world healthcare ecosystem.